that there was treatment, and that I could have a good quality of life. So being a part of this community has been rewarding. I've made many friends and connections, and that has supported me and given me the strength and knowledge to become an advocate for us people living with MG. Today, I want to share a little bit of history about the support group. Now, I believe this group was started in the late 1980s by Dr. Theo Monset. If I'm wrong in him starting it, he was the leading physician, medical advisor that was a part of the support group at that time, and he was a well-known neurologist. He's the one that got Dr. Weinberg involved in the late Dr. Weinberg, in the late 1989, around 1989. And it was in the late 1990s that we started having our November annual meetings. And this was to bring the physicians and neurologists and patients and caregivers together. As a result of COVID, we're doing this virtually today, but the intention is for us to share our stories and get to meet other people living with MG. I just want to recognize some of the people that in the past that have really provided the support to get us to where we are today. I believe Deb Emery, Judy Weinberg and Paula Salem, Marilyn Buckner, and Pamela Sorello. Those were some of our past leaders that have volunteered their time, and I just want to recognize them and thank them. So today we have 4 of our MG neurologists that will be sharing their topics with us. They're volunteering their time, and we're very grateful for that. And I have to say a big thank you to Dova Levine, Angela Pontus, Craig Reese, Denise Trombley for their efforts, because without the support, I wouldn't be able to put on what we're doing today. So I just want to say thank you to everyone. And then for those who contribute their stories for today, thank you as well. So at this time, I'm going to turn it over to Dova Levine, the National Senior Director for Program Management and Education from MGFA. Dova.
Hi there, thank you. Do I have co-host rights?
You do have co-host rights, and I'm stopped sharing.
Okay, I am good. So I just wanted to share for a few minutes and thank our sponsors. So I'm speaking on behalf of the Myasthenia Gravis Foundation of America. I'm on the staff there as the Senior Director for Programs and Education. So these sponsors support all of our regional meetings across the country: Alexion, Argenix, Janssen, UCB, Immunovant, Horizon, Accredo, and Sanofi. So I just wanted to mention one event and one new program that we have at the MGFA. So very exciting, our National Patient Conference will be a hybrid meeting next year, March 26th to the 28th in New Orleans. And right now on their website, you can register for the in-person meeting, and we will be, there will be an option for the streaming or Zoom virtual attendance, but it's not there now. So for now, you can register for the in-person meeting on our website. The other thing I wanted to mention was our new online community. This is a new program that we have, and it's different than our website in that it's interactive, and we have all different buildings that you can go to the town hall, you can go to the museum, you can see the history of the MGFA. In our wellness center, we have a fitness center, we have a nutrition center, you can see recipes. We're going to have cooking demonstrations and live fitness demonstrations. There's also an industry center, which will have individual offices from each of the sponsors who want to have an office there, and they can put up any of their information that they want to share with patients. We also have a founder's wall and a memorial garden. So I really encourage everyone to go and take a look at this. It's pretty exciting, and you can interact with other people, and it's a pretty innovative online community. So I will stop sharing, and thank you, Glenda, for letting me present those things. And let's have a good meeting.
Thank you. Okay, believe it or not, we're ahead of schedule.
Miracle.
Before we start, I just want to remind everyone to stay on mute. And also, if you have any questions as people are presenting, just put them in the chat. And for those of you who haven't lived on Zoom for the last 2.5 years, the chat box is at the bottom of your screen. Click on it, and then a panel will appear. Mine appears on the right side. So just put in your question. We will collect them and try to answer them at the end of the meeting. If not, be assured that your questions will be answered at some point. Some people submitted them ahead of time, and we will respond to those in real time at the end of the presentation. Okay, so the first presenter is Dr. David Weinberg, who's the Vice Chair of Neurology at St. Elizabeth's Medical Center in Brighton. He has over 35 years of focused care for MG patients. He's a member of the MGFA Medical Scientific Advisory Board, past chair of the New England Advisory Board, and associate professor at Tufts. He's considered professor emeritus, medical advisor emeritus of the MGFA. His presentation, as you always look forward to, is on the MG landscape that's ever changing. And he presents it in a very clear and understandable way. So I'll leave it to you, Dr. Weinberg.
Thank you very much. I appreciate that. Now let me just share my screen and get the program up. Well, good afternoon. It's a great pleasure to be with you today. I'm sorry that we can't be together. It's been one of the great events of the year to get together and spend time, have a lunch, or usually a brunch. And I hope that maybe next year or the year after we'll be able to do that again. It was a great yearly experience. So this is a very exciting time in myasthenia to be a myasthenia doc, and that translates into be a very exciting time to be a patient. The opportunities are changing, and so I'm going to talk today about some of the evolution in our treatment thinking about myasthenia and the way that I think it's going to translate into care. So I'm going to start with a little timeline. So this is, let me get the pictures out of the way here. So there has been quite an evolution in the care of myasthenia. When I started in this business, there were very few therapeutic options. Prednisone and pyridostigmine started in the early 60s. They changed the entire landscape of myasthenia. Generalized myasthenia patients died at an unbelievably high rate, 30%-ish in those days. And these treatments completely changed that. So a big evolution with prednisone, pyridostigmine, then azathioprine, cyclosporin, IVIG came into common usage, and plasmapheresis in the late 60s and early 70s. And then there was very little that happened. Mycophenolate in its different forms was added in the 90s, which was a very helpful addition. But then really nothing until really the 2018 to 2022 frame. And that's what we're going to spend our time talking about. What's happened now, this explosion of new options for treatment of generalized myasthenia. And I want to spend the next 15 minutes or so talking about how these drugs work and the role I think they're going to have in the marketplace. So I'm going to go through each of these drugs so you have some idea of where they are in the pipeline and what the differences are between them. So first, let me just say that, so the treatments that we used in the 60s, 70s, 80s, and 90s still form the core treatment medications for generalized myasthenia. So we consider these the core drugs, and most people respond to these drugs. So the response rate of remission or near remission is in the 2/3 to 3/4 range. So 70+% of people have a good response to these drugs, and you don't need to think about doing anything else. So the core group of people respond well, and then the people who don't, which is a significant minority of patients, 25, 30%, we call refractory generalized myasthenia. And it's the refractory group that the new medications are really designed to treat. I think that's going to change down the road, but that's the way it is right now. So what is refractory medicine? So refractory myasthenia gravis is a situation where a patient fails to respond to adequate doses, and that's very important that you receive adequate doses of what we call the conventional or standard therapies. And that's the prednisone, azathioprine, mycophenolate medications. And so if you fail to respond to those medications, you're considered refractory myasthenia. And then we have new options. And how we use these options depends in part, there's a lot of factors that go into it, but it depends in part on your myasthenia gravis status. So acetylcholine receptor antibody myasthenia is treated a little differently than the others. Acetylcholine receptor antibody myasthenia represents around 80% of all generalized myasthenia patients. So it's by far and away the largest group. MuSK patients are going to be in the 5% range, LRP4 probably in about the 3% range. And then seronegative for all three of those antibodies is going to be a little over 10%. So the antibody status does influence what treatment option is available at this time. And the designation of these drugs for different subtypes is going to change over time. We only have the initial clinical trials that we're working off so far. So we're going to talk about three different kinds of medications: the complement inhibitors, the FcRn blockers, and the B-cell depleters, B-cell depleting therapies. So first, complement inhibitors. Now, in order to tell you how these drugs work, I have to talk a little bit about the whole system of damage to the muscle that occurs. And we've done this before. So this is the neuromuscular junction. This should be a kind of familiar cartoon to you. And let me get a pointer. So on the top is the nerve. This is the nerve up here. This is the space between the nerve and the muscle, and this is the muscle down here. So this is where the postsynaptic membrane, we hear about the postsynaptic membrane. This is the postsynaptic membrane. It's on the muscle fiber itself. And when the nerve fires, it releases these little red dots, acetylcholine molecules. They go over and they interact with these purple oblong structures, which are the acetylcholine receptors in the muscle fiber. So the nerve fires, release acetylcholine. The acetylcholine binds to the receptors, and very predictably, the muscle fiber will fire. So when the nerve is active, the muscle fires, and it's an excellent system. It really is very predictable and consistent as long as there isn't disease. And obviously myasthenia is that disease that interferes with this system. So how does it do it? Well, it does it with these guys. These upside down Ys are the acetylcholine receptor antibodies. And the acetylcholine receptor antibodies interfere with the receptors so that the acetylcholine can't activate the muscle fiber and lead to a contraction, and that causes muscle weakness. So one of the things these antibodies do, and this is a little complicated, is they activate this system referred to as complement. And that's what this is trying to design to show. So Complement is a protein system that assists antibodies in damaging the bad guys. So there are certain bacteria and cancer cells and things that antibodies alone can't adequately control, and the antibodies combine with complement to kill the bad guys, and they're really very effective at destroying tissue in concert together. The antibodies identify the tissue, and the complement destroys the tissue, the bacteria or the cancer cell. And it's a very effective system in the immune system. It's part of the immune system. But what happens in myasthenia in some patients is that these antibodies activate complement as if they were trying to destroy a bacteria that was difficult to control. And the result of that is it actually damages the receptor and the muscle fiber itself. And complement causes incredible damage of the muscle fiber at the neuromuscular junction in myasthenia. So by blocking this system of complement activation, which is what these drugs do, the antibodies can attach the receptor, but they don't induce complement destruction of the receptor and the membrane. And in some patients, that's been very, very effective therapy at preventing the damage to the receptor. Now, some patients with generalized myasthenia have antibodies that don't activate complement, don't cause weakness this way, and the medications aren't designed for those patients. And the way you find out is you treat someone, and if they get better, then you have a pretty good idea that they activate complement. And one of the major antibodies that activates complement is the acetylcholine receptor antibody. For example, we know that the MuSK antibodies don't activate complement. So this medication wouldn't work for MuSK myasthenia. So these are the clinical trials. These are the drugs that have been used that are complement inhibitors in clinical trials. And you're very familiar, I'm sure most of you are familiar with eculizumab, which is Soliris, which was the first, and that was approved by the FDA in 2018. And earlier this year, Ultomiris, ravulizumab, was approved. And ravulizumab is very much like Soliris, eculizumab, except that it's designed to be in the body longer. So instead of requiring an intravenous infusion every 2 weeks like Soliris, Ultomiris is an IV infusion every 8 weeks, which is certainly a lot more convenient. I've been very pleased with the response to these drugs in some patients, and it'll be interesting to see how the panel, what their experience has been. Zilucoplan is another complement inhibitor that has completed phase 3 clinical trials. There's an application to the FDA that's been completed, and there should be a response from the FDA at some point in the first half of 2023. And this should be a nice addition to the group of complement inhibitors, because it's a subcutaneous form of treatment that can be done by patients at home. So it's a whole different option for a delivery system. It's also not a monoclonal antibody, and that'll matter in our next discussion. I'll explain why that's important. So the complement inhibitors, very important development in treatment, and eculizumab and ravulizumab have been released for treatment of patients who have refractory generalized myasthenia gravis that is acetylcholine receptor antibody positive. That's the group of patients that this is approved for. We'll see what happens with Zilucoplan, how they'll release that, what groups they'll release that to, but my expectation is going to be the same. Every patient who receives a complement inhibitor has to receive vaccine coverage for meningococcal disease, because that's one of the bacteria that complement is designed to control. And it turns out that if you don't vaccinate for it, there's a risk of getting it, and it's a bad infection. So that's the underlying nature of the complement story. It's a much longer story, but I have to keep it nice and tight because I'm going to stay on time today. Because I know Denise is going to tell me as soon as I get close to my time. Now I want to tell you about the FcRNs, and the FcRNs require that you understand the structure of an antibody. So here's a primer about antibodies. This structure is an antibody. It's an IgG antibody. And there's two parts to an antibody. There's the top part, referred to as the FAB fragment, and there's the bottom part, referred to as the FC section region. The FAB part is the business part. So that has a receptor that binds to specific antigens. So the acetylcholine receptor binds specifically to the acetylcholine receptor antibodies, bind specifically to the acetylcholine receptor through the light chain portion. That's why we showed them upside down on the diagram. The bottom portion, the FC section, is exactly the same in every IgG antibody. Now, there are whole kinds of other antibodies, IgA, IgM, IgE. None of them have an FC section region, only IgG. And what that's used for is to bind to a receptor, an FC receptor that recycles IgG. So instead of getting broken down, IgG is recycled through an FC receptor in the body, so that IgG hangs around the body like about 21 days, and all the other antibodies last only about 6 days. So it keeps these antibodies circulating, and when they're good antibodies, that's great, but when they're bad antibodies, these acetylcholine receptor antibodies, they keep hanging around and damaging the muscle fiber. So they had the idea that if you could shorten the half-life of IgG, and that means removing a lot of the IgG from the blood, then maybe it would improve the myasthenia. And they've done excellent clinical trials for that. And these are the FcRn blockers that are either in clinical practice now or in clinical trials. So the only way to find out if this concept works is do clinical trials. And the first one was efgartigimod, which you know is Vyvgart. It's the one with the TV commercials and all that. And so this was the first FcRn blocking medication that was done in a clinical trial in myasthenia, and it turned out it really helped. The data is quite compelling. This is delivered intravenously 4 weeks in a row as a kind of unit, and then there's a gap of time, and then it's repeated. And in order for this to be effective, it has to keep being repeated. And that's true for a complement blocker as well. I didn't mention that, but in order for the medication to continue to work, you have to continue to block complement. So efgartigimod was released earlier this year for intravenous use. The efgartigimod subcutaneous form just completed their clinical trial, and they've submitted application to the FDA for approval of that. And this would be a home injection that patients can do themselves, that you could do yourself, but it would be given the same way as the IV form. It would be given 4 weeks in a row with a gap, which varies, but typically is around 2 months, and then have the whole sequence 4 weeks repeated. Now, there are other forms of FcRn blockers that are also in clinical trials, and rozanoliximab is a subcutaneous form that has also completed clinical trials, and an application to the FDA has been submitted for this drug too. And this is another subcutaneous form, and the FDA is going to have to decide what schedule they're going to permit. The clinical trial used several different schedules. We'll have to see what the FDA decides is appropriate, but I do expect this drug will be approved as well because the data was good. And so there'll be other options for other patterns of dosing that will be available in the next 6 months is my expectation. There was another drug that doesn't have a name yet. It has a number, RVDT 1401. This clinical trial was put on hold for elevated cholesterol levels. It's now starting phase 3 trials, so that's a ways away. Nipocalimab is another drug that's in clinical trials. Phase 3 clinical trials are ongoing. It's probably going to be another year for that. That's given intravenously every 2 weeks. So a single dose given every 2 weeks. And there's a subcutaneous form that's being evaluated of nipocalimab as well. So there's going to be a whole host of FcRn blocker clinical practice opportunities in the next year or two. So more options. Now, there's the concept that if you have an antibody that activates complement, if you reduce the antibodies and you block complement, the two should work pretty well together. So using them together makes a lot of intellectual sense. Unfortunately, Vyvgart would remove Solaris or Ultomaris from the blood and can't be used together. So there's some challenges in using some of these drugs in combination, but I think that can be overcome in the future. So we're going to see the combination of this being another addition to our treatment armamentarium, the two concept drugs being used together in the future. I'm pretty sure that's going to happen. But the last topic I want to mention quickly are the B-cell depleting therapies. So in order to tell you about that, I have to tell you that B cells have these receptors on their surface that identify them as B cells. And there are monoclonal antibody drugs that attack these receptors and destroy the B cells. And by doing so, they remove just the B cells, and the B cells are the cells that make the antibodies. So by depleting the B cells, you're reducing the ability of the body to make antibodies, and that includes the acetylcholine receptor antibodies. And there are two drugs that are either in clinical practice or in clinical trials. And the first is rituximab. Rituximab is a drug that's been around for 25 years, being used for use in cancer, using that mechanism of action of attacking B cells. And it's been used in myasthenia for a number of years off-label. But the studies in myasthenia have been a little inconsistent. It's predominantly used in muscular myasthenia, where the data is very strong compared with alternative therapies for refractory patients. The first clinical trial in acetylcholine receptor antibody positive myasthenia was an equivocal trial, the BEAT-MG trial, which we've talked about before. But there was recently a clinical trial out of Scandinavia, which suggested that using rituximab early in acetylcholine receptor antibody myasthenia might be very effective, which would really change the way we do things a little bit right now. Another opportunity to use a new kind of drug in probably severe acetylcholine receptor antibody positive generalized myasthenia. But the jury's still out on that. That came out about a month ago. And I don't know how we're going to integrate that just yet, but I'm interested to see what other people have what they think about it from our panel. And inebilizumab is another monoclonal antibody that is being used now for some other autoimmune neurologic diseases, but there's a clinical trial going on in myasthenia, and that should be completed in the coming year too. So it'll be very interesting to see if they get a positive result on this trial using B-cell depleting therapy. So just kind of summing this up, it's an incredible time in the treatment of myasthenia. This is the first opening shot of new creative therapies. There are going to be more concept drugs coming out. Right now, we're only using these drugs in refractory myasthenia, but there's no question that they're going to move earlier in our treatment paradigms. And I would envision 10 years from now that we're treating generalized myasthenia gravis completely different than we're doing it now. So a lot of very, very exciting options for treatment. So thanks for your attention. I hope I didn't go over by too much.
Perfect. Absolutely perfect. Thank you so much. It
Thank you.
is so exciting to see. It's unbelievable. And also, just so you all know, these slides will be available, so you'll be able to study them even further. Our next guest is Dr. Pushpa Narayanswamy. She's an associate professor in neurology at Harvard Medical School and vice chair of clinical operations, Department of Neurology at Beth Israel Deaconess Medical Center in Boston. She serves on the Medical Scientific Advisory Board of the Myasthenia Gravis Foundation of America. She was part of the international panel that developed consensus guidelines for the management of myasthenia gravis, and that is her topic. For those of you, it's unbelievable that consensus can be reached among so many people nationally or internationally. So I applaud you for herding cats.
Thank you, Denise. Thank you for that very kind introduction. And you were absolutely right. It was a true herding cats business. So that sums it up perfectly. So I'm now an expert in herding cats. Maybe that's something I should be adding to my CV here. It's a pleasure to be here. And Dr. Weinberg, your talk really set the stage. And some of what I'm going to talk about sort of incorporates material that you mentioned in a very broad manner. So without further ado, let me find my slides. Here we go. And can you see the slides?
Not yet. Oh, there they are.
Yes.
I'm going to get them on presentation mode. Good.
Looks good.
Okay, thank you all. Okay, so my topic, as Denise mentioned, is the international consensus guidance for the management of myasthenia gravis, and I'll be talking mostly about the 2020 update. We first published this in 2016. These are my financial disclosures. And so why do we need guidelines in myasthenia gravis? Dr. Weinberg gave you a lot of information, for instance, about the newer drugs that are coming up. We also have similar trials about many of the older drugs that we use in myasthenia gravis. What is the meaning of evidence in myasthenia gravis, or in any disease, in medicine for that matter? Evidence is the body of data, the results of all trials, the results of different types of trials, the results of case reports, the results of case series, and the results of people's expertise, and so all of that body is considered evidence. And you have to have really strong evidence. And what does one mean by strong evidence? Strong evidence means you can trust the study and you can believe the results of the study to be close to the truth. We don't know what the truth is, right? If we knew what the truth was, we don't have to do a study. If we knew that this drug was effective in myasthenia gravis or was not, we don't have to do a study. But we do a study because we don't know the answer to that. And the results of each of those studies form the body of evidence. Now, remember that studies are not just for treatments. Studies can be to look for tests for diagnosis. For instance, when the acetylcholine receptor antibodies were developed, then there were studies looking at how good they were in diagnosing myasthenia gravis, which means how many people with myasthenia gravis had the antibody and how many people without myasthenia gravis didn't have the antibody. So it has to be specific, it has to be sensitive, all of these matters. So in myasthenia gravis, because of various factors, the evidence base for treatments, and here I'm just talking about treatments, not diagnosis and other factors, can be difficult to interpret. For instance, this is a study, this was an evidence-based guideline. So they took all of the studies for plasma exchange in myasthenia gravis. And I'm sure all of you know that plasma exchange is a very potent, very effective treatment in the setting of crisis or rapidly progressing myasthenia gravis in order to turn patients around quickly and effectively. Now, this is what the evidence-based guidelines said about plasma exchange in myasthenia gravis. It said that there was insufficient evidence to either support or refute the use of plasma exchange in myasthenia gravis. Now, that makes no sense to you all when you know what myasthenia gravis does, and it didn't make any sense to us either. Why was it like this? Because there were only 2 studies that formed the evidence base for plasma exchange in myasthenia gravis. One of them compared plasma exchange to pyridostigmine or mestinon, and that's like comparing apples and oranges. You know, who compares plasma exchange that makes the disease go away, removes the antibodies, to pyridostigmine that helps with improving symptoms temporarily? The other study looked at plasma exchange in patients who underwent thymectomy and compared those that received plasma exchange before thymectomy and those that did not receive plasma exchange before thymectomy and looked at them. Now, why was it this way? Think of how plasma exchange is used. Plasma exchange is used in very sick people who are maybe on a ventilator in the ICU. How can you compare it to another drug? So how can you have a control group where you say, I'm not going to give them plasma exchange. I'm only going to give, randomize half the people to plasma exchange. The other half, when they're acutely sick, is not. It's not ethical to do it. So you can't have a high level evidence. And therefore, what we need is a guidance or guideline where we have consensus from experts. So people who have a lot of experience in taking care of patients with myasthenia gravis, they sit down and they say, well, this is my experience. And then one comes up with some recommendations. Why? Because regardless of what the quality of the evidence is, we still make treatment choices for all of you. We talk to you in clinic and tell you how this works and how this doesn't work and what we would recommend for you. And the evidence is not great. And there is therefore this uncertainty about how each of these options work. And that is the reason practice in myasthenia gravis varies widely. So then why is the evidence not strong in myasthenia gravis? We are getting there. I think the studies that Dr. Weinberg quoted and all of the upcoming studies, the evidence is very strong because they are robustly designed and executed clinical trials. And more importantly, many of these drugs seem to work really quickly. So we don't have to do a trial for 6 months and 1 year to find the effect. And that can be expensive. It can be very difficult to do, for instance, a trial of a drug that takes, for azathioprine, for instance, can take 12 to 18 months to act. And the evidence is really not strong because it takes so long. And the disease is a rare disease. So to recruit adequate numbers of patients and to retain them in the trial, to make sure that they're able to come back for follow-up for a long period of time, every month, say for 18 months, it's very difficult. And then there are study-related factors. So Dr. Weinberg mentioned the mycophenolate story, and it's interesting because the mycophenolate story is that we think it works, but there are 2 randomized controlled trials, very powerful trials that say it doesn't work, but we still use it. And I'm sure there are some of you who are on mycophenolate. Why is that? So it's interesting because we just finished a study called the PROMISE MG study that I will not be discussing. I'll talk about it perhaps when we have the QA session, where we found that mycophenolate can take up to 17 months to act. And so if the studies were 12 to 36 weeks and a 6-month study, they didn't find effect. So that may be why. So those are trial-related factors, design-related factors. And then how we select subjects for the trial may be a problem. And also outcome measures. There is that inherent variability in myasthenia gravis, you know that, and our outcomes may not be sensitive to capture that inherent variability. So what did we do here? In 2016, with the support of the Myasthenia Gravis Foundation of America, we had a task force with 15 members, I think, representing 9 countries. And we used a very specific formal consensus development process in order to develop these consensus recommendations for the treatment of myasthenia gravis. The first step we did was to say, hey, okay, look, before we jump into this issue of what treatment and what not to give, how about we standardize some definitions? And that's one thing that was an important part of that process. And then in 2020, as Dr. Weinberg mentioned, eculizumab had been approved in 2017. The thymectomy trial was published in 2016, and the BEAT-MG trial was published. Well, it was published recently, but it was completed and we had some data. So we updated that guidance, and I'll talk a little bit more about it. The first thing we did, and I think which is very important, this was really sort of the first time this had been addressed formally, was to say, when I'm treating my patient, what is my goal for treatment of myasthenia gravis? So when I'm seeing you in practice, what do I want to do, to help you? So I want to get that disease pretty much gone. And how do we define pretty much gone? We say that you cannot have any symptoms. We don't want you to have any symptoms or functional limitations from myasthenia gravis, but you may have some weakness on exam when we see you. For instance, your eye closure may be a little bit weak, but that's okay. It's not affecting you functionally, but that's not enough to make the disease burden, to reduce the disease burden. We also want to make sure that we don't do it at the expense of serious side effects. We don't do it at the expense of side effects which impact your life so badly that in some ways the treatment of the disease is worse than the disease itself. And so there are various ways of measuring that. And we said, look, if there are mild side effects, we don't have to make any changes. We can just observe. You are okay with just observing those, that's fine. But anything more means we haven't achieved the goal for treatment of the myasthenia gravis. And so some of the topics that we addressed in the International Consensus Guidance are listed here. Many of them were addressed in the 2016 guidance, and then we added a few, as I mentioned. We added the ocular myasthenia gravis portion. We talked about these new drugs listed here and that Dr. Weinberg mentioned. And we also added the immune checkpoint inhibitor section, because these drugs are more and more used for for malignancies. And we know that they have a risk to cause various neurologic side effects, including myasthenia gravis and inflammation of the muscle. So what did we say about thymectomy? Our data was based on this randomized trial published in 2016. So what did we say? So again, the data here, or the information here on this slide, is so that you can read it later. That's why there's so much information. But basically, we said that in patients with myasthenia gravis, acetylcholine receptor antibody positive, and who don't have a thymoma, because if you have a thymoma, the thymus needs to come out to treat the thymoma. Here we are talking about treatment of myasthenia gravis with the thymectomy. So we said that thymectomy should be considered early in the disease to improve clinical outcomes. So what clinical outcomes? It reduced the dose of prednisone that was needed. It minimized requirements for azathioprine, and it minimized hospitalization for disease exacerbations. We also said that if patients with generalized myasthenia gravis with acetylcholine receptor antibodies fail to respond to an initial adequate trial of immunotherapies, so either prednisone or azathioprine, or have intolerable side effects from that therapy, we should strongly consider thymectomy and sort of go forward with it. One of the issues was that in the study of thymectomy, they did this long sort of involved surgery where basically they cut open the chest like a cabbage, like a coronary artery bypass grafting, and remove the thymus. But now we don't do that. We do these robotic and endoscopic thymectomies, and we don't have really the data for that. So how much can we carry that data to here? I think it's something that bears discussion. Surgeons often say that, yes, they can take out all of the thymus even with those approaches. So it's important to keep that in consideration. we can consider thymectomy in rare seronegative patients, so acetylcholine receptor antibody negative patients, if they fail to respond to immunotherapy. It doesn't help in MuSK myasthenia. Let's see. Oops. Okay. The ocular myasthenia gravis evidence came from this trial called the Epitome trial. And this a retrospective study where they looked at immunosuppressive treatments other than steroids for ocular myasthenia. And as you know, ocular means it just involves the eyes. So our recommendations were that typically when it's ocular only myasthenia gravis, we use pyridostigmine for symptomatic relief. We sometimes add prednisone, but it's important that when we do add prednisone, one thing to realize is, unlike a generalized myasthenia gravis, it's likely that ocular myasthenia gravis needs only a tiny dose of prednisone, maybe 20 to 30 milligrams. That's important in the setting of both short-term and long-term side effects. And again, if steroids are contraindicated, they don't respond to pyridostigmine, and they are refractory to immunosuppressive agents, we talked about the role of thymectomy, but we don't know exactly the role of thymectomy in ocular myasthenia gravis. This would be a small population of patients. There is an attempt at doing a trial on this in the future. Dr. Weinberg mentioned eculizumab. This is the REGAIN trial that was effective in actually getting the FDA approval for this drug. And we did say that it should be considered in the treatment of severe refractory acetylcholine receptor antibody positive generalized myasthenia gravis, because that was the trial population. And we said the role of this was likely to evolve over time. We have to think about cost of treatment, etc. And it's really important to follow the recommendations of the Advisory Committee on Immunization Practice, which is a committee that provides advice to the Centers for Disease Control regarding immunizations, because one of the risks of eculizumab is because it inhibits that complement formation, is that it can cause infections due to bacteria that have a capsule around them, the commonest being the meningococcal bacteria and the gonococcal bacteria. Meningococcus causes either meningitis or it can cause bloodstream infections. And then immune checkpoint inhibitors, as I mentioned, they are molecules that are present in our body. They are present on the surface of certain types of immune cells called the T cells, and they prevent host tissue damage. So they prevent damage from our own immune system. So when our immune system creates a response to something, to a bacterium or to even our own tissue, as in myasthenia gravis, where our immune system is fighting against our own tissue, these immune checkpoints prevent that damage. But in cancers, there are antibodies to these checkpoints that block these checkpoints and actually stimulate that immune system to attack tumors. So you're attacking the tumors not with chemotherapy, but with the immune system of the body. And these can cause adverse events, including myasthenia gravis. And our recommendation was that the risk of myasthenia gravis and other immune-mediated neurologic illness should be discussed with patients who are candidates for immune checkpoint inhibitors, and that we have to be careful about the myasthenia gravis associated with immune checkpoint inhibitors because it's generally severe. They can need respiratory support. And what happens if somebody who already has myasthenia gravis requires immune checkpoint inhibitors? So I think because the cancer can be so invasive and so dangerous, obviously that takes precedence, and therefore we recommended that even in the setting of myasthenia gravis, we can use these treatments, but with certain precautions that are mentioned here. And then I think this a couple of final slides. Rituximab, the BEAT-MG trial, that was a negative trial. So it really did not show that rituximab over a period of a year was able to reduce the requirement for prednisone. And therefore, our recommendation was, so as Dr. Weinberg said, the consensus was that there is enough evidence that it's useful in MuSK antibody positive myasthenia gravis. So that's what we said. But even there, it may not be the initial drug, especially because there are many of them are women, young women of childbearing age, and rituximab use in childbearing is a problem. And then we did say that it's uncertain in the setting of acetylcholine antibody positive myasthenia gravis. The Swedish trial was not published at that time. Methotrexate, again, same difference, that it was not effective in reducing steroids. Now, remember, that does not mean that if one of you is on rituximab and is working great, or on methotrexate and is working great, you have to change your treatment. So I think that's really important to take home, that these trials show us group effects, but individual effects may be very different. And so we said, again, methotrexate may not be useful. So, and again, this is what I was mentioning. These recommendations are just intended as a guide to clinical management. They're not intended for payers to say, I'm going to deny this drug. And this continues to change. Now, we will probably update this guideline. What we're waiting for, despite the approval of these a couple of drugs, is to get a little expertise and experience in using them in clinical practice. Thank you very much. I think that's my last.
Thank you. Wonderful. Again,
I don't know how late I was. I'm sorry.
No, you're only off by 1 minute. This is good. Thank you so much. That's incredible information. And by the way, again, all this information will be available to you so that you can analyze it at a later date. But thank you. Next is Dr. Michael Heyer. He's an associate professor and division chief neuromuscular medicine in the Department of Neurological Services at the Robert Larner, and I hope I pronounced that properly, College of Medicine at the University of Vermont. Dr. Heyer's clinical research and educational interests are in the evaluation and management of adult and pediatric patients with neuromuscular disorders, particularly myasthenia gravis. His topic, and I think everybody's going to be really interested in this, is measuring adverse effect burden in myasthenia gravis. So we all understand it. So Dr. Heyer, it's all yours.
How's that? Can everybody see my slides? Awesome. Well, thank you so much for having me. It's a pleasure to be here with all of you. Thanks for taking the time out of a Sunday with beautiful weather. I don't know what it's like down in Massachusetts, but up here it was 70 degrees and sunny in Vermont today, which is unbelievable in November. So everybody set me up really nice for the talk I'm going to present right now. Just to my disclosures, I do some consulting for companies that make medications for myasthenia. And this talk was actually, the research that I'm going to discuss today was all sponsored by the Myasthenia Gravis Foundation of America, as well as the American Academy of Neurology. So thank you to them for supporting what I think is a really important line of research. So I'm going to talk a little bit about goals of care in myasthenia, to help sort of frame the idea of what we're going to talk about today. We'll talk a little bit about adverse event burden and development of a new way to measure side effects for myasthenia and for other conditions, and talk about some future directions. So I start every talk with a slide from my mentor, who unfortunately we lost this year. I don't know how many of you knew Ted Burns. But he did amazing things for patients with myasthenia over the course of his career. And I always think about what would Ted do when I think about what I should do with patients or with research or whatever. So what Ted says is the goals of care in neurology are really to keep people safe and alive, help people do the activities they want to do. And number 3, limit symptoms and adverse effects and minimize disease effect on the quality of life. and give people a better future. And, I think it's an exciting time, as Dr. Weinberg mentioned earlier. But I think for me, and probably for all the other docs on the session today, as well as for all of you patients, this is a little bit what it feels like when you're choosing a medication for myasthenia these days. It's nice that we have so many options, but it's like looking at the beer case at City Market in Burlington and looking at all the different Vermont beers and which one am I going to choose? So I'm going to talk about a new way to sort of compare these treatments and how we might compare them in a different way and compare. So when I think about treatments, I think about value. And we think a lot about clinical benefit and quality of life, and a lot of these medicines are going to be similar with regard to clinical benefit. So how do we choose among them? And one way to think about choosing among them is to think about the things that might be negative effects of these medications, such as financial cost, side effects, and treatment burden. And in fact, when we were preparing a grant a couple of years ago, we surveyed patients and physicians, and we asked people, what are your concerns about long-term immune system therapy in myasthenia? And the first thing we learned is that patients and physicians are very concerned about long-term medications. And the things that they were most concerned about were long-term side effects, current side effects, cost, and treatment burden, all the things on the bottom part of that equation. So the talk today is going to focus on the adverse event burden part of that equation. And when I think about it, are we capturing adverse event burden and myasthenia well? And there are some tools to do this. Some of the tools are medication specific. So in the rheumatology community, they have a unit that measures the burden of steroids. But as you know, we just learned there's many other different medications that we use in myasthenia. We don't just use steroids. So that's not really a great way to do it. Some of these measures are disease specific, and none of those diseases that have been studied are neurological. Most of them are there. So hypertension or schizophrenia has a unit. We think about quality of life questionnaires. But as I'm going to show you, that those questionnaires don't necessarily capture side effect burden. And then there's unweighted lists of adverse events. So there's a unit that the cancer community developed called the CTCAE that measures side effects and puts them in different categories. But if you read medical papers, this is what we learn about side effects when a clinical trial is done. So at the end of a clinical trial, there's like a table 4 or a table 5, where they list out the side effects that patients in the treatment group and in the placebo group had. And you can see here's that table from the efgartigimod trial, and then on the right is the table from the eculizumab trial. And you can see things like headache and nausea and diarrhea and upper respiratory tract infections. And we get kind of percentages of these things that happened during the trial. And that's okay. But it's sort of a very granular look at what might be happening. And it certainly doesn't allow you to compare efgartigimod to eculizumab based on their side effect profile. I like to think of it, because I'm a tennis player, about sort of thinking about where somebody serves the ball once. You can sort of measure that and look at it. And that's kind of like saying, okay, there was a headache. But what you really want to do is measure where you serve the ball for the entire match. So this is Roger Federer in Wimbledon in 2012, and we know exactly where he serves the ball every time that he serves it. And you get a much more clear picture of what's going on in the match. So what our goal was to develop something that would allow us to get a clearer picture of adverse events and be able to compare medicines across different classes. So to be able to compare efgartigimod to eculizumab, to prednisone, to mycophenolate, to azathioprine, all medicines that have different groups of side effects that occur with them, but we wanted a way that we could compare them using a single metric, kind of like comparing the cost of those things using something like $1. So what we did is we came up with 73 categories of side effects that we thought were relevant to patients with neurological conditions, including myasthenia. And we had physicians and potential patients weight our unit. And we published that earlier this year. And what we designed is we kind of know what the side effects are that should be associated with different medicines. And we now have scores that we can assign to these categories of side effects. So here, what I'm depicting is somebody with myasthenia who's being treated with mycophenolate. And we get a certain list of side effects that could potentially occur with that medicine. We ask people, are you having any side effects? And they say, yes, I am having side effects. And this person lost some weight. So we clicked yes. And they lost 10 to 20% of their body weight, which when we weighted things had a score of 4 out of 10. They are also having diarrhea. It's not really bad diarrhea, but it's happening. So that got a score of 2. So at the end of this clinical visit, this person has a side effect burden score with the adverse event unit of 6, which could be followed over time. You can see, does this score go up from visit to visit? Does it go down from visit to visit? If it's going up, do you make a medication change? So what we did is we wanted to try and use this unit for a year. So we used it for a year at our clinic at the University of Vermont. And we just wanted to see how useful was it? What kind of information did we get? Was it new information? And how hard or easy was it to obtain this information in our clinic? And we had 54 patients that we followed for a year, 65 times. So some of the patients were seen more than once. It was 50-50 exactly, male to female. We had an average age of 64, which is typical of our population in Vermont. About half of the patients were acetylcholine receptor positive patients. About half were seronegative, and that's because we have a lot of ocular myasthenia patients in our clinic. And then people were treated with typical medicines that we treat patients for with myasthenia, or we treat patients with myasthenia with these medicines. And what we found, which is very different than some trials that we'll learn about in the future, is that 78% of our patients reported side effects in this trial, which I thought was very interesting. And it's because we were focusing on them. And what we learned was, this is sort of a fancy plot that basically we compared adverse event unit scores to the MG Quality of Life 15 score. And what we found is they track together a little bit, meaning that the adverse event burden score sort of contributes to the quality of life. But it's not the quality of life instrument doesn't reflect the side effect burden on its own. We're measuring something new with this unit. The other thing we learned was here we're depicting the number of medicines on the left part of the graph. So 1, 2, and then 3 to 4. And I'll call your attention to the median score here. And you can see that as you go from 1 medicine to 2 medicines, your median side effect burden score per visit goes from 1.5 to 3. And then once you're on 3 or more medicines, it goes up to 7. And that is exactly what anybody would expect. So the more medicines you take, the more likely you are to have side effects. So our unit is sort of measuring what we think it is, side effect burden, and it's providing new information that's not covered with the quality of life measures alone. The other thing we learned is that it's pretty easy or fast to administer this unit. So we had an average of 4.8 minutes to administer the AEU score versus 6 minutes that it takes to do the ADL and the QOL 15. So the way I interpret this is that it takes about the same amount of time and it takes about 5 minutes. Some other stuff that we're learning. So here's a table like a table that you might see at the end of the clinical trial. And this is just percentages of people that are having different side effects. And this is not exactly what the AEU is designed to do, but I think people want this information. They want to know, what are the side effects that are contributing to these scores? And I sort of highlighted ones that I thought were interesting. So in red, malignancy, secondary to medication is something that we're all very concerned about. You can see that we saw that in our azathioprine patients. And this patient who was on eculizumab was also on azathioprine. We think about diabetes for our patients with prednisone. So about 20% of our patients had diabetes. We think about weight gain with prednisone. One that I think is super interesting, and people have been talking about it a lot, is diarrhea. And diarrhea is often attributed to pyridostigmine, but it's becoming increasingly common to recognize it with other medications. And you can see here that 50% of the patients on eculizumab had diarrhea. A quarter of the patients who are getting IVIG. The one to focus in on is mycophenolate. So there were a lot of patients who were getting mycophenolate who were not getting pyridostigmine who had diarrhea. And I think that's an increasingly recognized side effect. But what we want to do is compare the medicines head to head based on their scores. So we did it with sort of single drugs. And on the right here, you see the AEU score. The higher the score, the more side effects a person is probably having, or the burden of side effects is greater. And you can see actually eculizumab had the highest score if you just look at these one by one. And one way to interpret that is that the majority of our patients who were on eculizumab were also on other drugs at the same time. And we know that the more medicines you take, the more likely you are to have a side effect. Prednisone had a lower AEU score, and I think that's because a lot of our patients are on very low dose prednisones. They're doing very well, and we tend to wean it down to as low a dose as they'll tolerate over time. But I thought this was interesting. We're looking at it like this too, where we see patients who are on multiple medicines. So you can see in the middle here under my pointer, this is somebody who's getting pyridostigmine, prednisone, mycophenolate, and they had a mean AEU score of, these people had a mean AEU score of 7.3, which would be kind of high based on the data we've gotten back. Here's a patient on eculizumab and prednisone whose score was close to 10, or these are 4 patients who are on both of those who had a mean score of almost 10. So we're trying to crunch it this way too, to try and account for patients who might be on multiple medicines. And there's some statistical ways that we're going to work on this. But I think this is something that we think about a lot, is getting our patients to low dose prednisone. And I think there's a lot of arguing that goes on about whether or not being on low dose prednisone is as bad as being on higher dose other medications. And when I looked at our data, we compared patients who were getting more 10 milligrams or more a day of prednisone versus those getting less than 10 milligrams a day. There was a difference in their side effect burden score. So the median score, the middle score for greater than 10 was 8 versus 5 for those on less than 10. It almost met statistical significance. We like to see a 0.05%. But what this means is that there's a 6% chance that there's no difference between these two numbers based on statistics. I also crunched it because a lot of our patients are treated with mycophenolate. For patients who are on full dose mycophenolate, so greater than or equal to 1,000 milligrams per day versus those on less than 1,000 milligrams a day. And again, we see a big split in the AEU score. There's an 8% chance that this difference is not real. So that's kind of the early data on our prospective trial, which we hope to publish later this year. But we have some plans for the future. So I've been given access to the randomized controlled trial of thymectomy and myasthenia, where they kept very close tabs on side effects in the trial in a way that I'm able to translate the way that they measured side effects in that trial into the AEU scores. So we're going to be looking at that with data expected in the spring. But I'm also working on a collaboration with the NIH MGNet Rare Disease Consortium, where we're going to follow patients at 4 to 5 centers for 3 to 5 years. And we're expecting an NIH R1 submission in the spring 2023. I also hope to start to use this unit in other neurological conditions. So I've been talking to physicians who treat patients with epilepsy and neuropathy and some other conditions. So I appreciate you listening to my talk today. Hope I didn't go too long. There's a lot of treatment choices for myasthenia, cost, AE burden. treatment burden are going to help us distinguish among those medicines, and more work is needed to understand the adverse event burden. So thank you for your attention. It's almost winter time in Vermont. I always show my kids skiing. My daughter at Smuggler's Notch. It's my other daughter who's the only snowboarder in our family. So come visit us. Thanks for having me.
Thank you so much. This was absolutely fascinating. I'm sure most of us can't wait to read some of the final information that you come up with. Thank you very much. Our next guest is Dr. Amanda Guidon. She's a neuromuscular neurologist at Mass General Brigham and an assistant professor of neurology at Harvard Medical School. Dr. Guidon participates in clinical trials in myasthenia and serves on the medical and scientific advisory board of the Myasthenia Gravis Foundation of America. She's board certified in neurology, neuromuscular medicine, and electrodiagnostic, boy, that's a mouthful, medicine. Dr. Guidon is also our current medical advisor for the New England Support Group. Her topic is the BioDigit MD, MG, and ADAPT tele-MG studies. Can weakness in MG be measured and monitored remotely? I have to tell you that I had to look it up, but it sounds like it must be fascinating. So it's all yours, Dr. Guidon.
Great. Thank you so much, Denise, and thanks to everyone for having me. It's wonderful to be here with everyone today. And I just want to thank all the speakers who came before me. Those were really fantastic talks and really, really informative and just wonderful talks. So thank you. And I think hopefully this will kind of touch on points from each of the talks. So it's a little, you'll hear some things again and then recognize kind of how we fit these thoughts into context. And so I'm going to talk today about telemedicine and remote and digital monitoring in myasthenia, and discuss why we started thinking about this topic and then how it has evolved over the past couple of years. So these are my disclosures. Again, I also do some consulting for companies that make medications for myasthenia, and I've received research funding from the MGFA, MGNet, and several other foundations, and the NINDS at NIH. And so we're going to talk about just the background of how this came to be. The first project on digital phenotyping of MG. We're going to briefly touch on the MG core exam, talk about our two ongoing studies. Some of you may have participated in the ADAPT tele-MG trial, and then the BioDigit MG, which is going to be starting up, and then next steps. And we're going to do it all in 20 minutes because I have my stopwatch on right here. Okay, so we've heard today about how heterogeneous myasthenia is, right? So it's a snowflake disease. No two patients are exactly alike. And so, when you start to try to really group patients and make sense of the heterogeneity, you get tables like this, which look very complicated and busy. But really, it's needed to understand what the very specific and subtle and not so subtle characteristics are of clinical presentations, the pathophysiology, and then some of the other associated features. And when we're thinking about treatment goals, we think about, as everyone has talked about today, that a patient comes in with symptomatic myasthenia and a diagnosis is made. Often there's like an arrow before this arrow because it's such a long journey to diagnosis for many people. And then we try to do the most tailored treatment possible to increase the efficacy of neuromuscular transmission. So back to Dr. Weinberg's slide of the neuromuscular junction, we want to make that as efficient as possible. And then to Dr. Harer's point of reducing side effects, that's an additional treatment goal. And we want to reach minimal manifestations, which is a treatment goal for many patients with myasthenia. And what that means is basically that patients may have some weakness on examination, but they have essentially no symptoms of myasthenia. And so we have several different ways of measuring this. So very nicely outlined in the 2016 consensus guidance statements that Dr. Narayanaswamy discussed. we talk about severity class, so all the way from remission and ocular all the way to crisis. And we have a whole litany of MG specific scales that are both scales that you complete as patients and that we complete as physicians, and some are a combination of both, to really understand different aspects of the disease and how you're doing. And some are used mainly for research, and some are used in the clinic when you come into clinic to follow. And there was a nice paper written a couple years ago by Dr. Mapidi out at Stanford about how you kind of incorporate these into clinical practice. But there are limitations. Sometimes, the limitations of that whole process is diagnosis. So we've all, heard about reduced clinical awareness that led to delay in diagnosis or referral. Myasthenia antibodies are typically negative in ocular patients, which can lead to diagnostic delay, and then there's seronegative. Some patients don't have access to MG specialists or centers, and then the outcome measures may not be routinely utilized outside of dedicated MG clinics and even in MG clinics. And the objective scales are subjective. So, one person might say that slurred speech is moderate, and one person might say it's mild or even absent. And so how do you get around that variability? And then the scales have not been validated for remote use, and they may not measure all relevant domains of disease. And so there was a very interesting study out of Toronto that was published in 2020 in Neurology, which is one of our main general neurology journals, by Dr. Barnett and her group. And she does a lot of work into outcomes in myasthenia. And she and her group proposed what was called the patient acceptable symptom state of myasthenia. So all of those scales kind of boiled down to one question. And that one question is, considering all the ways that you are affected by myasthenia, if you had to stay in your current state for the next months, would you say that your current disease state is satisfactory? And there were certain kind of thresholds that were defined. And this was really quite interesting. They looked at over 1,000 patients in the clinical setting with all those different types of myasthenia. So early onset, late onset, thymomatous, non-thymomatous, and they found that overall, about half of patients were, depending on how you look at it, in an acceptable state, or if you're looking at the glass half empty, we're not in an acceptable state. And so that is pretty striking, that despite all of the advances that Dr. Weinberg talked about in his initial slide, we're still in this state where a lot of people just don't have, it's not acceptable. And so there was another study that was also published around the same time, where with an accompanying editorial, which was a Swedish group of generalized myasthenia patients. And similarly, there was a low, I'm not going to go into these data, but people were getting better in terms of weakness, but just not doing well overall. And so you say, okay, well, why is that? And so Nancy Law, who unfortunately passed away recently, but was the former CEO of the national organization of MGFA and a patient with myasthenia herself, did a qualitative study looking at evaluating patients with myasthenia to talk about the lived experience. And she and her group really defined the 9 different disease domains. So there's the physical, and that's really, the physical effects of medications and all the physical effects of MG weakness, psychological, social, reproductive and parenting, activities and participation, whether the disease is controlled or not controlled, this whole separate area of when there's flare-up or crises, the treatment burden. So what is the travel burden? What's the medication administration burden, the financial burden, and then all of those unmet needs. And it's a very interesting paper, to read, but basically it talked about unmet needs in many of those areas. And so we started thinking, like, around even before the pandemic, about wearable sensor and digital technologies digital technologies to be able to assess and do remote monitoring of symptoms and weakness in myasthenia. So where did this come from? Well, a growing use of wearables in all areas of medicine to accurately measure small clinically meaningful change. And what that does is that if you think that a clinically meaningful change is smaller, you need fewer people in clinical trials to be able to possibly demonstrate that change. Where if you are trying to look for a large clinical change, you need a lot more people in your clinical trials and you need to follow them for longer. So it could really improve the efficiency and lower the burden and cost of doing clinical trials. Also, with all the new FDA approvals in the pipeline, we really needed improved outcome measures to perform comparative effectiveness research, like the work that Dr. Narayanaswamy has performed with PCORI, looking at CellCept versus azathioprine. And that list of drugs is just going to keep expanding of drugs that we need to compare. There is growing interest in wearables and telemedicine as really the backbone of a hub and spoke model of care. So could there be like a hub specialty hospital and patients could get care more locally, closer to home in less specialized centers? And then the possibility to increase access to bring expertise to underserved areas, improving timely care, so reducing that first arrow before the arrow, the delay to diagnosis and timely care, and then reduce the burden of seeking care. And so when we think about the time frame of treatment of myasthenia, many people, but by the time they reach diagnosis and undergo early treatment, and then spend a long time weaning prednisone and then weaning their immunosuppressive agent if they're possible, it can be a multi-year process. So could we really shorten that and attain some treatment goals sooner and at lower costs with the less disease burden? So that same equation that Dr. Hare was talking about in terms of values and treatment goals. And so we initially designed a study that was funded as a pilot grant by MGFA on digital phenotyping. And this was to determine if computer-based remote assessments were feasible and acceptable in MG patients. We started the protocol in 2018, but then, and it was funded and ongoing right during COVID, right in the heart of COVID. And so all of the in-person assessments that we had planned were totally impossible and suspended. And so we, with the agreement of the MGFA, transitioned the protocol to an entirely remote protocol. And we actually began to enroll even in the height of COVID, aiming to enroll 20 patients and 20 controls over 6 months. And what this study is that MG patients and controls were enrolled. We changed the focus of the study to looking at all assessments that we could do remotely and not wearables. We obtained virtual consent. We did speech surveys and computer mouse surveys weekly for 4 weeks. And then quality of life scales, again, weekly for 4 weeks. And then we did a feedback on the study at the end of the 4 weeks. So our hypotheses, so what we expected to occur was that the format would be feasible, as indicated by 70% survey completion rate. And we chose that number because, typically that we thought that would be an acceptable and is kind of an accepted rate of completion. If you're doing, a survey intervention, that you would think about using it, and that the format would be acceptable and that people want to do the activity again in the same or shorter form. And so the speech tasks that we collected were variable. It was about 10 minutes, and people had a program on their computer, and they pressed a button and recorded speech and then did these various tasks. And it looked like this. That was like an example of a screen. And then we did a computer mouse task. So this protocol was initially designed for people who had ataxia and other neurologic disorders. And the coordination for using a computer and mouse can be very impaired in that disorder, though less typically in myasthenia. But we did it as another possible, technique that we thought would not be as relevant to compare to the speech data, which we thought would be very, very relevant. And these were our key baseline characteristics. And this manuscript is in preparation. Basically, our mean age was middle age in the 50s. The control age was slightly younger. We did not match for age, just given the more observational study. Patients were mostly female. English was the first language of most people. And in terms of myasthenia severity, it was mostly ocular and class 2, so mild disease, and that was based on the prior clinic visit, though some people had more severe disease. And these are, in terms of the feasibility outcome, this was indicated by greater than percent as we predefined, greater than 70% survey completion rate. And this indicates the speech surveys, the computer tasks at week 1, 2, 3, and 4, and then the patient reported outcomes at week 1 and week 4. And this is the 70% line. And we can see that, and the darker bar is patients with myasthenia, the lighter bar is controls. And so this select group of patients with myasthenia had a very high completion rate, completion through the end of the study on tasks that were relevant. So less so the mouse task, but more so the speech task. But we did see a drop off in participation over the course of 4 weeks, though still it remained 70%. When we asked about whether the format would be acceptable and people would want to do it again, there was a very high rate of acceptability. So 76% of the 26 myasthenia patients said that they would complete the full assessment again, and 89% of the controls. And mostly what was most interesting and what people most enjoyed, interestingly, were the speech surveys. So almost 50% of people said that what they enjoyed most was the speech surveys. And what I thought was very interesting is that, things that we think about with quality of life surveys, very few people said that that was what they enjoyed to do most. And that's what we do a lot of times to monitor patients. People felt it was, feasible, just the right length. And so what we found was that this format was feasible and acceptable for, number one, obtaining virtual consent, MG specific scales and quality of life data, and the specific tasks with a computer and recording interface. For some patients, our coordinator provided some additional support, but it was really a minority, and most patients were able to complete this independently. We realized that it would be important to design any study like this with a variety of support. So some people are going to be totally independent and other people are going to need more support. And so to have that variety of support present, and then to get feedback on people's experience after 1 week, because we were worried that by waiting to the end, we didn't capture people who might have been dropping out. And then really selecting the outcome measures to reflect the symptoms in MG and be highly relevant to patients would really be important for engagement. And so around the same time, we started having a need for clinical scale to measure weakness remotely in myasthenia. And a number of myasthenia physicians, including Dr. Hare, and I came together to be able to form what was called the MG core exam. So this was a consensus-based exam. It was not as rigorous a consensus as Dr. Narendaswamy defined, but we needed to do this relatively rapidly during COVID to be able to continue to see patients. And we defined how we would incorporate the core exam components into a telemedicine clinic visit. And this was an example from the manuscript of how we talked physicians step by step through how to perform this and then how to score it over telemedicine. And we, just because we devise an exam doesn't mean that it's reliable and accurate. It really needs to be studied. And so with MGNet, which others have referred to, we, as part of the natural history study, developed a sub-pilot project to look at this exam and other virtual exams to see if they were reliable. And we looked at whether if 2 people performed it with the same patient, they would agree on the scoring. And then we looked at if the same person does the exam at different points in time with the same patient, will the examiner agree with him or herself? And this has been ongoing for about 9 months now or so at different sites around the country that are part of MGNet. In addition to these sites, we have 2 independent raters who review the videos remotely, and then an adjudicator to address any disagreements between the 2 independent raters. MGNet is just a remarkable structure that involves many people at different sites and has been a real, I think, benefit, to myasthenia that will continue to produce data for many years to come. And what we did for this study, was basically enroll patients from our clinics and then complete all of these scales on day 1 and then several days later at the same time. And these were in stable patients. And we are looking to enroll 50 patients altogether. And in terms of where we are in the recruitment, so we've recruited about 80% of patients so far, and we're aiming to complete by the end of 2022. We still have the room to enroll several more patients from each of the sites, and we're working to do that over the next several weeks. And so then we thought about, okay, this is one, scale, but what about that idea that we couldn't do during COVID of really doing digital phenotyping of patients with myasthenia and being able to monitor remotely? And so a couple of years ago, MGNet and myself started speaking with a company called Biosensics, who was interested in this and had developed technology for other diseases. And we, after a couple of years and refining the milestones, we just were funded with a technology transfer grant. It's called a SBIR. And this is a 1-year grant. And then if these milestones are met, then it will extend for several other additional years. And this is to develop an app to remotely monitor symptoms of myasthenia. We will conduct stakeholder interviews with patients and then with physicians and demonstrate feasibility and assessment of myasthenia using the app from 20 patients. Right now, we are developing the app to be able to capture speech data and extraocular motility and ptosis data, and then we're going to assess the use and usability in stakeholder interviews. So eventually, this will have 2 components: a wearable and then the app, which will communicate with one another. And this first phase is designing the app. And so in the interest of time, I'm going to skip over the other 3 aims, but it is basically looking at feasibility, acceptability, and those next steps. And so we will be enrolling for that study in the winter time for patients with myasthenia, initially just at MGH, though we hope that potentially with additional funding, we would be able to expand to other sites. And so in the last couple minutes, I just want to say, where this fits into the landscape of treatment for myasthenia. And so, really this remote monitoring and telemedicine will be one part of the picture, but there are many other parts. So data without context and expertise, and then that analytic infrastructure is really not informative and really can be harmful. So I think we need to collaborate in these aims and really be smart about what we're measuring, how we're measuring it, and making sure we have a representative group of patients who we're working with. And so, we are really trying to, work with colleagues and with the participation of patients in these clinical trials to get out of the silo of individual sites, to be able to collaborate on these projects and increase the numbers to be able to make more meaningful conclusions about our data. And so we hope that over time, we'll be able to make this process of discovery really a natural part of patient care, to be able to look at outcomes for all patients who consent, not just the patients who are involved in interventional clinical trials, or even the small numbers who are involved in observational trials. And this really does work to maximize healthcare value and quality improvement over time. So in conclusion, can weakness in MG be measured and monitored remotely? Well, probably to a certain degree, but we need to study it more. We're developing the remote outcome measures and monitoring systems we've talked about too. There are others. And then ultimately, can it improve outcomes and lower disease burden? Well, there's a lot of work to do on this, developing experience in larger databases, data platforms for how to integrate these data into a clinical workflow and really give real-time feedback to be able to risk stratify. So to say, okay, you know, we're seeing you in clinic, you're at high risk of a more severe course. How can we stratify you based on specific criteria to more intensive monitoring and treatment? And can we do this over space and time? We're really excited to be part of a new center at MGH called the Center for Value-Based Healthcare and Sciences, to be a partner in this mission. And so in summary, there's been lots of progress, gaps, and opportunities in MG care. We talked about digital phenotyping, telemedicine, and utilization data. The remote technologies have potential to be a growing part of healthcare for MG. However, additional relevant tools and study are needed. And then towards this learning healthcare system where we can aggregate large healthcare databases supported by systems to interpret the data and then to implement the findings and improve over time. So a big thank you to all patients who participated and who have supported this work and other work, the funders, so MGNet, MGFA, and a collaboration with Biosensics and some others who are listed on the slide, and all mentors, colleagues, teachers, and collaborators listed here. So thank you.
Thank you. This looks absolutely fascinating, and that technology will certainly increase accessibility to people throughout the country and maybe throughout the world to treatment and help for myasthenia and other diseases. So thank you for that work. Are you all set, Dr. Guidon, with questions, or do you need time? Because we can flip the next 2 agenda items, I think.
Whatever works best, we can go to the Q&A.
Okay,
That is totally fine.
Okay, if you want to lead that.
What's that? Yep, absolutely. So,
Okay.
So next we'll go to our Q&A session, which has been a really big and important part of this meeting that has been led by Dr. Weinberg, where people would submit little pieces of paper with questions. So the little pieces of paper equivalent today is the chat. So thank you for submitting questions both in advance and otherwise. And I think that we'll start with the questions that were submitted in advance. And so we'll alternate between the physicians on the panel. And so the first question is for Dr. Narayanaswamy. So with all of these projects that have been discussed, can you talk a little bit about how does a research project get selected? How is it funded? How do people select what they're going to work on? And then how much choice does the individual investigator versus the hospital or universities have?
Sure. Thank you, Amanda. So this is getting at that point that I made about generation of evidence. How do we then generate data about various aspects of myasthenia gravis, so for that matter, about any topic in any area of medicine? So that can be in various methods. So for instance, here you've heard some of the trials that each of us have been involved in, and those have arisen out of our own passions, out of our own questions that we've asked during our experience seeing you all. So you have contributed to our research in that way, because you bring up questions that we are unable to answer, that we don't have data to answer, and we try and translate that into a formal research question, and then we find opportunities to fund that research. And I'll come back to the funding question in a second. So this is something that in a sort of medical parlance or trial parlance is called investigator-initiated trial. So it's something that an investigator initiates. So the investigator themselves find the question, and then they find a way of answering the question. And there's multiple steps before you answer the question. So it's not quite as easy as it sounds, unfortunately. The second way is oftentimes industry-sponsored trials. So what is an industry-sponsored trials? When a drug company, for instance, Alexion, developed a drug molecule for eculizumab, and then they did some initial trials on animal models, perhaps, or on cell cultures, so out of the human realm, just to sort of figure out how these medications act. And then they did some safety trials in healthy volunteers, and then they did some safety trials in people with myasthenia gravis. And then they really wanted to prove that effectiveness of the medication, so they set up this huge randomized controlled trial and invited. Those are called industry initiated trials. So the sponsor for those trials is industry. So you have investigator initiated trials, you have industry initiated trials. And then the final way is when granting organizations themselves call for trials or proposals for specific topics. They may say, proposal for instance, a proposal for new treatments in myasthenia gravis, or a proposal for measuring outcomes differently in myasthenia gravis, which would be Dr. Guidon's project, So they call for those proposals. And usually what's happened is people have been working on this in the background a little bit. We have some pilot data, we have some small data. This is an interest of ours. And then we say, okay, fine, this is really good. Let's go and apply for this grant proposal. So those are sort of the mechanisms. Now, who are the funding organizations? The funding organizations are various funding organizations. We heard about some of them. Foundations, for instance, the Myasthenia Gravis Foundation of America actively encourages research protocols, especially with the MGNet now. There's a huge push for even bigger studies. So that's one. Then you can have, of course, industry, the sponsor of the industry sponsored of the industry or pharmaceutical initiated trials are the pharmaceutical companies. And then you have granting organizations like the NIH, the Patient-Centered Outcomes Research Institute, etc. So that sort of is the way to funding. And I think, there was a question about a bottomless pile of opportunities to choose from. I don't think so. I wish they were, but I don't think so. It can be difficult to get funding for trials. A lot of work goes into it. There's a lot of competition. So I don't think there's bottomless. And is it your choice, the hospital or the university's choice? And I mentioned that the actual question may come from the investigator. It's usually not the hospital or the university's choice. It's the investigator's choice, or the pharmaceutical company's choice, or the grantor's choice. I don't know if any of you, Mike, Amanda, David, you have anything else to add to that?
I think that's a great description, and really, really clear. I don't have anything to add. Does anyone else want to add? Okay, great. So the next question is for Dr. Weinberg. There are lots of new drugs for myasthenia. How or where, besides from our neurologist, can we get information about each of these and their applicability to our individual situations? And then what are the things as a physician that you consider when deciding which MG drug to recommend to your patients?
Those are excellent questions and very, very difficult to answer part one. I'll just say this, that these drugs are straightforward in terms of how they apply to criteria of myasthenia. And so the FDA has released these drugs with very specific application to different situations within the myasthenia gravis community and the cases, but applying it to individual cases is extremely difficult. And trying to determine what's the right drug for you is not something you're going to be able to determine by reading about them. It's the kind of thing that has to be discussed with your neurologist because there's a lot of issues to weigh. There are factors about compatibility between the treatments you're currently on. If you need to remove one of the treatments you're on in order to start a new medication, what are the implications of that? What can be used together? I mentioned that a little bit. That conversation is a very long and interesting conversation, but the short answer is it's actually a complicated decision process now. It used to be fairly straightforward. There were a few options. They actually were pretty similar. There were some side effect differences to talk about and things like that. But the reality now is that this decision is much more nuanced, and I wouldn't try and do it alone. Now, there's nothing wrong with reading about these drugs. And if you go to the manufacturer's websites, they will give you the party line about these drugs. They'll give you the FDA decisions about how to apply it. But that won't help you decide, is this the right drug for you? It really is a much more complicated and nuanced decision. But read about them, prepare, and then when you sit down with your doctor, you can have a really meaningful conversation about what issues are most important to apply to your particular case. And it really dovetails well into the second part, is how does a physician decide what medication to recommend to a patient? And again, it's the same process. It's a very nuanced process that applies a number of different things simultaneously. You've already heard about the important burden of medication complications, Dr. Hare earlier, and that has to be weighed against the potential benefits of a drug. So those are the two fundamental things. It's just, could this drug help you? And if it could help you, what are the possible consequences of using this drug in your particular case, the risks? So everything in medicine is a risk-benefit decision. And although that decision may seem straightforward sometimes, you have to then adjust your decision-making based on what happens. So it's a constant process of reevaluation. Are you getting enough benefit to justify the side effects and the risks? Sometimes the side effects and the risks are different. The side effects might be nausea or headache, and you can report to your doctor that those things are troubling you, but there also is a risk of inducing a malignancy that you really have no idea if that's happening in the background, or the risk of developing diabetes or osteoporosis, things you have no idea based on how you're feeling. So all these things have to be taken into consideration as you decide what's the right treatment for your particular situation.
Great, excellent. And so I think we're running up to the end of time, so we'll do one more question, and then I'm going to go through the chat briefly and do like a yes, no, like comment, just so we can address some of the other questions that are there, if that's okay with the other panelists.
That's okay. I think people are interested in the question, so if it goes over time, no worries.
Okay, all right. Denise, you tell us when to stop, okay? And when we're moving on. Okay, because there are lots of great questions. So, so Dr. Hare, can you talk about the attribution of causality in the AEU? Like, how do you decide whether a side effect that somebody's experiencing is actually related to the drug? And that gets back to a question that is, discussing potential liver issues for patients who are on long-term prednisone, that may or may not be related to prednisone. What if it's reported? What if it's due to another medication they're on?
Thanks. So I'll take the second part first, I guess. So I don't usually think of liver dysfunction, unless you do, as a major problem with prednisone. Although in theory, I suppose you could get like fat deposition in the liver over time if somebody gains a lot of weight on prednisone. I think most of us tend to think about liver issues with azathioprine or Imuran, and actually typically monitor liver function or liver enzyme tests for patients at some regular interval who are on that medication. There's been a signal in some of the newer FcRn drugs for possibly raising pancreatic enzymes. So that's something else that people are sort of keeping their eyes on for some of the newer medicines now. I think, yeah, so that's what I have to say about the prednisone question. As far as causality, I think that's it's a tricky thing to do. The idea, it's easiest to attribute causality to something if somebody starts a medication and something happens soon after starting it, like within a few weeks or a few months of starting something. It's easier to attribute a side effect to a specific treatment, but I think over time it becomes less clear. And I think, we haven't followed a lot of patients for prolonged periods with very carefully monitoring what could be considered side effects, either things that people tell us about in clinic or things that we learn about in laboratory tests, like, for example, following somebody's liver enzymes over time. Those things would score on the unit that we've developed. So if you had somebody whose liver enzymes were sort of creeping up over 3 years' time, their score would probably be going up in relation to that. And I think we need more data to try and understand it. Some of the things that people do report to us may not be side effects of the medications that they're on. One way to figure it out is to stop whatever you think the offending agent is and see if that particular symptom goes away. But yeah, it is tricky, but I wouldn't want to not measure side effect burden because there are theoretical examples or examples where it may not be perfect. You don't want to, as Ted Burns would say, you don't want to throw the baby out with the bathwater. And that applies to all these metrics that we use in myasthenia, the ADL, the QOL-15, the single question. There are some times where it's not going to reflect the actual clinical status of any particular person. But for the conglomerate of people, it does seem to do that. And the same with Dr. Guidon's unit that she was discussing earlier for following patients, which we use in our clinic. It's great, but it doesn't work for everybody. That's my answer.
Great, excellent. And so I think it would be helpful to talk about the questions related to efgartigimod and eculizumab. And so the question is, maybe we can all just speak to this for a second. We can start with you, Pushpa. Do you have patients who are using efgartigimod? How is it going? And are you noticing side effects? And then what are the data for eculizumab in patients greater than 80? And are you using eculizumab in patients greater than 80 years old?
Okay, thank you. So I'll take the efgartigimod question first. Yes, I think I have 4 patients at this time on efgartigimod. It's been relatively early days since I started it in most patients. So I think it's a little bit of a mixed bag, but overall, and I have to say that these are difficult to control, patients with difficult to control myasthenia. They've had myasthenia for a long time. They've been on multiple medications. And so these would be considered refractory, although I think that's a term we are moving away from a little bit. So we have to take that. So it's not like the trial population. The population of patients in the trial did not have to have refractory myasthenia gravis. In fact, did not have refractory myasthenia gravis. So it's a little bit of a different population. And I have found, though, that it seems to be pretty useful in improving symptoms quite dramatically, in bringing down their activities of daily living score, etc. What I haven't found quite yet is whether I can get them down to minimal manifestations. I can taper them off of prednisone, for instance. And also, I haven't found yet the optimal duration between the doses, because as Dr. Weinberg mentioned, in the trial, they waited for patients to get worse before they gave them another round of efgartigimod. In clinical practice, I don't want to wait for anyone to get worse. I want to get at that before they get worse. And it's hard to tell what that period is. And I think time will tell. And I also have a feeling it's going to be different for each patient, just like we do with IVIG. Some patients get it every 4 weeks, some patients get it every 3 weeks, etc. Some patients wait, 3 months between infusions. So that's in terms of the efgartigimod. I don't, for eculizumab, I don't recall the age population for regain, but I do think it was less than 80. So I don't think we have data for patients above the age of 80 from the trial. In clinical practice, do I use it? Yes, I do, if it's indicated. And I will mention here that Dr. Weinberg mentioned this when we talked about, when he answered the question about choice of treatments. So one of the things that I think has happened is we are always looking at side effects too. I mean, I think we've talked enough about it to say we are looking at effectiveness, but we're also looking at side effects. I think the needle has moved in using these medications a little bit earlier when significant side effects are a real concern. So even before those side effects happen. So in patients who are older, who have hypertension, diabetes, osteoporosis, reflux, and you cannot use steroids. And you need a quick response because steroids, act quickly. I mean, they're a great drug. If only they didn't have some of the side effects, they'd be perfect. So in patients, but then Mike wouldn't have his AUU. So let's not go there. So at least not for prednisone. So that's the issue. So when we need that really quick response and side effects are a real problem, then these medications may come in useful earlier on. So that the whole algorithm of myasthenia gravis treatment is going to change over time as more and more of these medications are available, including using them earlier on, including not waiting for patients to get really sick or fail 3 therapies before we get to these therapies, etc. So I think lots of things going on. I don't know if that answers. Was there another question about eculizumab? I think that was it.
No, that was it. Yep. David or Mike, other thoughts to add?
I would just say, Mike, you go ahead.
I was just going to say we have an older population here in Vermont, so I have used Ultomiris, ravulizumab in patients over 80, and they've done well. Seem to respond the same as my younger patients who might take that or eculizumab.
Same here. Yep. David?
Right. Yeah, I don't have a lot to add. I would just say that in my experience, the medications have all been very well tolerated, which is a really important piece of it. And I think it's a little too early to know how well people are going to do. I've been pleased with Ultomiris in terms of clinical response. I've been surprised. But the efgartigimod, it's a little too early to know. But people have tolerated it well, which is the first hurdle.
Yeah, I would agree with that. I mean, I think that the patients who have had best response are either using those drugs earlier on in disease rather than the very, very refractory patient, or are refractory because of side effects and not because of lack of disease control on other medications. So not unexpected. I mean, it's similar to all the other drugs we use. I think that, if we use it early, it can be better, or if, it's not a super refractory patient. Of the super refractory patients, if patients have responded well to plasmapheresis in the past, that would be a reason, to potentially consider efgartigimod and hope for additional benefit as well. That's been my experience so far. Denise, should we transition over?
Yeah, I was going to add to that question, pediatric myasthenia.
Yeah,
because that was a
Yep.
question that came in, and a
Yep.
lot of people are interested in that. And so those kinds of drugs, particularly the newer drugs for the pediatric folks.
Yeah, let me just say one more thing about pediatric MG. So there is a big need for other options in pediatric MG. It can be an added challenge because we typically don't do thymectomy before puberty. And so that is an option that comes in later. Additionally, a lot of pediatric MG is seronegative or a larger percent, even if it's generalized. And so, we always want to be very sure that it's not a congenital myasthenic syndrome as well before we, use a lot of immunosuppressive therapy. And so right now, the mainstays of treatment in pediatric MG are generally IVIG or plasmapheresis, mainly IVIG, and then to a lesser degree, prednisone, because we want to avoid prednisone side effects, particularly in younger people. But there are ongoing trials now with complement inhibitors and the FcRn receptor antagonists for pediatric patients. And so we hope in the next couple of years that the indication may be broadened for pediatric MG that's acetylcholine receptor positive or seropositive.
Thank you. I want to be respectful of people's time. I know you've dedicated 2 hours to this meeting, so what we'll do is put the rest of the responses and make them available to you. And we've gone 10 minutes over. I don't know if people are willing to, particularly the physicians that have been answering these questions. If you're willing to go longer, we can go longer, or we can put it in the on the site. So your choice, folks. Thumbs up.
I think we should transition to the rest of the agenda,
Okay.
and that,
Okay.
yep, and we're happy to, I'm happy to, and others can answer the questions, yep.
Perfect. Okay, Craig, do you want to take over the stories? A lot of people submitted their stories or bits of their stories and how MG has affected them. And we have a very short, what is it, 10 minutes, Craig?
It's about 6 minutes. Yep. If I'm
Okay.
good with the mouse. Yep.
6 minutes. And we encourage you to continue sending that kind of thing in because it's really quite helpful. Go ahead.
Right. Yeah. I was say we reached out to people on our mailing list and in our Facebook group, which if you're on Facebook, that's called the MGFA New England Support Group, and asked people to the open-ended question, give us 2 or 3 sentences about the most impactful parts of your myasthenia journey, and collected those. And Angela put them together into this presentation. This is 100% her work. I'm sharing her work because she couldn't be here today. So let me go ahead and make sure I check the box to share the sound. And then find the right, there we go. And can you see that okay?
Yes.
We invited the community to share the ways that MG has impacted their lives. Thank you to those who bravely shared your stories. We hope by sharing each other's journeys, those living with MG do not feel alone.
See what I mean about the mouse?
A little louder if you can.
Yeah, I'm not sure where it's supposed to be sharing the sound. I'm not sure where that went.
I'm looking forward.
I can't control the volume, I don't think, on this
I'm
end.
looking forward to the day of leaving behind the 4 every other day of infusions I get monthly that are 6+ hours long for my MG. I will also be pleased not to have to drive the hour plus each way to get them. This would drastically improve my quality of life. Diagnosed in April 2021 at age 87. Thymectomy September 1st, 2022. Have been on prednisone, mestinon, rituximab, and apheresis, now every 3 weeks. Doing well, eager to reduce prednisone from 10 to 5. The most impactful part of my MG journey is the fact that I cannot get insurance approval to provide the new medication Ultramirus, which has been recommended by my doctor. Despite the fact that I went through a crisis, which including treatment with IVIG and plasma replacement, my prescription insurer, CVS, will not approve it. My open willingness to share my MG story has turned my unknown world of living with a rare disease into a blessing. Sharing my story across many different stages is my hope to increase the awareness of myasthenia gravis, educating others living with MG to advocate for themselves and the general public on the challenges of being diagnosed, finding the right treatment in hope of living a good quality of life. My open willingness to share. I was a healthy and active teacher who danced 4 times per week and traveled frequently. When my right eyelid closed and other symptoms continued to appear until I could no longer eat nor talk, it took over a year to finally be taken seriously and receive the care that I required. My new life is still a work in progress, but I am so happy to be able to dance again twice a week and resume my travels, even if they need to be at a more moderate pace than before. The fear of the unknown has impacted me greatly. The act of not knowing when my muscles will give out causes me to worry and creates more stress, which makes the situation worse. Learning how to cope with this is hard. Each day I have learned to assess how I'm feeling when I wake up. Some days are going to have to be restful days, and other days I will be able to do things. I have learned to pace myself and not schedule too many things on one day to overexhaust myself. If I do, the next day is automatically a rest day. I'm working towards acceptance that my life with MG will be different than what I am used to. However, I need to move forward and live. At first, I took this disease quite cavalierly, but still did lots of research. As the symptoms worsened, speech fatigue, lots of fatigue, I began to taper my activities and grow more concerned. All of this, for an Energizer bunny, was quite traumatic and somewhat overwhelming. Many different drugs were tried, and I failed to find just the right combination for about 2 to 3 years. I now have pretty much minimal symptoms. Of course, I've changed my activity level a bit, and am much more aware of times that I need to slow down. I know that it won't always be this way, so I learn to enjoy every moment with the people in my life. That is the gift that MG gave to me. Once I had trouble chewing and speaking and told my primary care provider that my dad had myasthenia gravis. I was diagnosed quickly in 2014. Since 2016, I have been free of all problems with my eyes, chewing, speaking, and swallowing. But I wake up every morning testing these basic functions when I wake up. MG became a part of my life at 38 years old and was certainly a challenge I didn't anticipate. I have learned that MG is a part of me and has taught me to be flexible in life. Thank
Sorry. The last slide was a thank you to everybody who participated and an invitation to keep sending those thoughts in if you haven't already, or if something else comes up. We're just going to keep collecting them and adding them into that presentation to share. Since we can't get together in person at this point, we thought that was kind of a nice way to let people share their stories that aren't collected on the the scientific and the diagnostic stuff, but how it's affecting you and what the big impacts are in your life. So back to you, Denise.
Thank you, and thanks to Angela as well. Since she's not here, we can appreciate her in absentia. And thank you all for participating. We're ever so grateful for so many people being here, learning, and assisting. And thanks to the physicians who just took time out of their Sunday. And thank you, Dova. More information will be coming forth. I don't have that slide, Glenda,